Great. Good afternoon, everyone. Thank you so much for joining today's webinar on hepatitis B and the opioid crisis. My name is Kate Morales. I'm the Senior Program Director of the Hepatitis B Foundation and Director of the Hep B United Coalition. So before we jump into the presentations, I'd like to review a few administrative items to let you know how you can participate in today's webinar. Please note that all attendees are in listen-only mode. You are muted during the presentations. For a stronger connection, or if you're having any difficulties with the audio, there is also a phone-in option, and the call-in numbers are listed here. Also, please feel free to submit questions in writing during the presentations by typing them in the question box on your GoToWebinar control panel. We will be reviewing them as they come in, and we will hold a Q&A period at the end of the presentation. And finally, today's webinar is being recorded, so you will receive an email with a link to view the recording after today's presentation. So a little bit about today's webinar. Hep B United and NASDAD are very excited to present today's discussion on hepatitis B and the opioid crisis. These are ongoing pandemics. They're very concerning as we're starting to see data released by the CDC and state health departments around the U.S. that parts of the country that are hardest hit by the opioid epidemic are facing a rise in acute hepatitis B infection associated with injection drug use. And this is revealing the very low Hep B vaccine coverage rates among adults. So our speakers today will discuss the rise in acute infection around the U.S., and specifically representatives from the Tennessee, West Virginia, and Maine health departments about how communities and their agencies are responding to the epidemic. Now, a quick overview about our host organizations. Hep B United is a coalition co-chaired by the Hepatitis B Foundation and the Association of Asian Pacific Community Health Organizations. We're comprised of over 35 organizations across 18 states, with a mission dedicated to reducing the health disparities associated with hepatitis B by increasing awareness, screening, vaccination, and linkage to care. And I'm going to turn it over to my colleague, Alyssa Kitlis from NASDAD.
Great, thanks so much, Kate. As Kate mentioned, my name is Alyssa Kitlis, and I'm a manager in the hepatitis program at NASDAD. And for those of you who are unfamiliar with our work, NASDAD is a nonpartisan nonprofit organization that represents governmental HIV and hepatitis programs, both in the US and globally. And our vision is to see a world free of HIV and hepatitis, and we work towards that goal by strengthening public health through advocacy, capacity building, and social justice. So one of the ways we do that is supporting health departments through convening calls and webinars like the one we're on today related to key issues that they're facing and facilitating peer information sharing and learning. So we're excited to co-sponsor this webinar today with Hep B United. And before we get started, we wanted to take some time to see who's on the call today. So we're going to open it up and do a quick poll to see who's joining. And we wanted to know if you are joining us from a health department, a community-based organization, a federally qualified health center, another national nonprofit, or another agency that isn't on that list. So we'll give it a minute here if you wouldn't mind responding to the poll and telling us who you are. And Kate, is the poll opening? For some reason, it's not showing on my computer. Oh, there we go. Found it. Perfect. So we'll give that about 30 more seconds just to get an idea of who is on the line today.
Looks like we're at 84%.
Perfect. Great. So it looks like a large number of state and local health departments making up the majority of the group, and then I'd be curious to hear where other folks are joining from. So if anyone isn't in that group but wants to share with us all where you're coming from, feel free to include that in the chat box. But a number of partners from CBOs and other nonprofits and federally qualified health centers. So welcome. We're glad you all are joining us today. And we also wanted to hear if you are seeing these same trends that we're going to be talking about on the webinar in your jurisdiction. So are you seeing rises in acute HBV infection in your community? So we'll take about 30 seconds to respond to that as well. And I know since this is new, a lot of you might not be sure, so we included an option for don't know.
Okay, it looks like we got almost 80%.
Perfect. Great. So it looks like quite a mix. A number of folks, 38%, are seeing these same rises in acute HBV infections. Some aren't, at 15%, and then about half of you don't know. So we're really glad you all are joining us today, and you know, look forward to hearing more in the Q&A about what you're seeing as well. But really appreciate you filling out those polls. And now I'd like to introduce our presenters. So today we're joined by 4 great speakers who will provide an overview of the trends that they are seeing both nationally and in their communities tied to acute HBV and the opioid crisis, and then also how they are responding. We're going to hear from Alice Asher, who's an epidemiologist in the Division of Viral Hepatitis at CDC's National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. Jeff Caulfield, from the Viral Hepatitis Prevention Coordinator at the Maine Department of Health and Human Services. Katie Pack, a hepatitis B epidemiologist at the West Virginia Bureau of Public Health, and Carolyn Wester, the medical director of HIV, STD, and viral hepatitis for the state of Tennessee Department of Health. And we're really grateful to all of our speakers for joining us today. And I'm going to turn it over now to Alice to get us started. So thank you, Alice.
Hi, thanks for having me today. Next slide, please. So I have nothing to disclose and just one disclaimer. Next slide, please. So people who inject drugs are at high risk of transmission of bloodborne viruses, including hepatitis B. And we know that the opioid epidemic and increasing rates of injection drug use are propelling hepatitis B infections in certain populations. And this is complicated by the fact that people who inject drugs are often considered hard to reach populations, and they're thought to be difficult to follow to vaccination series completions. And sometimes this requires then novel methods to engage this population. It's critical to success because the bottom line is hepatitis B is a vaccine preventable disease. Next slide, please. You're likely familiar with the increase in opioid prescriptions and subsequent misuse that began in the 1990s. By 2010, opioids generated $11 billion in sales, and in 2012, 259 million prescriptions were written for opioids, which is more than enough to give every American adult their own bottle of pills. Of the 20.5 million Americans 12 or older that had a substance use disorder in 2015, 2 million had a substance use disorder involving prescription pain relievers, and almost 600,000 had a substance use disorder involving heroin. Next slide, please. From 2001 to 2016, the number of reported acute hepatitis B cases declined 63%, from over 7,800 in 2001 to less than 3,000 new infections in 2012. We saw a slight increase of 5.4% to over 3,000 cases in 2013, and then again a small decline from 2013 to 2014. But from 2014 to 2015, cases of acute hepatitis B increased by over 20%. And in 2016, there was a slight decrease again. But as you can see, the marked declines we saw in the early 2000s are no longer occurring. Next slide, please. And again, while we're seeing incidence of hepatitis B decrease overall, we're actually seeing certain increases in certain age groups, and most notably that of adults who are ages 50 to 59, and as well as slight increases from about 2010 for people aged 30 to 39 and 40 to 49. Next slide, please. And when we look at this by race and ethnicity, we're also seeing increases notably among white non-Hispanic folks as well as people who have Hispanic descent. Next slide, please. In 2016, only 48% of reported cases provided any risk data for hepatitis B infection. And of those, only 22% who had information on risks actually have risk factors for hepatitis B infection identified. However, of those 22%, more than half report a history of injection drug use. And that represents a 10% increase from 2015, where 43% of people who of identified risk factors were associated with injection drug use. Next slide, please. An example of increasing hepatitis B due to injection drug use is the case of Florida, where they've seen significant increases in Pasco County from 2011 to 2016. And under investigation, it's in their most recent data, they're seeing that just this year alone, there have been 23 cases from January 1st of 17 to March of 2018. They're seeing this among people a lot of people have been hospitalized. And again, this is a hard to reach population, so people who report injection drug use and experiencing homelessness. Florida's been doing a lot of innovative work though in trying to improve vaccine delivery, including providing vaccinations in the emergency department through mobile vans in the county jail and utilizing the newest hepatitis B vaccine called Heplisave, which among other things has what we call high rates of immunogenicity, meaning that even after one shot, you can start to see the body mount an immune response. While we know that access to syringe services programs in Florida is somewhat limited, the state is doing a good job of trying to get vaccines out there, as well as communicating regularly with their state health department and the populations that most vulnerable to infection through a series of pamphlets, flyers, as well as news reports. Next slide, please. We've also seen a hepatitis B infection increase in Appalachia, in Kentucky, West Virginia, and Kentucky saw notable rises in hepatitis B infection from 2006 to 2013, the vast majority affecting people who inject drugs. Next slide, please. And here we see that vast majority of these infections occurred in non-metropolitan areas. Next slide, please. And these trends mimic what we're seeing in hepatitis C, which we, I think, have a much better sense of its connection to the opioid epidemic and to injection drug use. So much like hepatitis C infection, where we're seeing equal increases among men and women and the highest rates occurring in non-metropolitan areas, we're seeing this track similarly throughout the country for hepatitis B. Next slide, please. So some of the drivers behind injection drug use in hepatitis B occur because hepatitis B is extremely viremic. It's an efficient virus and it can spread through all drug paraphernalia, not just needles and syringes. It also has a very long survival period on inanimate objects. And if you took one drop of blood that hypothetically had hepatitis B, hepatitis C, and HIV, and someone came into contact with it, they would have a 30% chance of getting hepatitis B compared to a 1.8% chance of getting hepatitis C and a 300% chance of getting HIV. Next slide, please. So just as a reminder, when we think about who's actually supposed to get vaccinated for hepatitis B vaccine, it's a variety of adult populations, and this includes people who are at risk for infection by sexual exposure and persons at risk for infection by percutaneous or mucosal exposure to blood, which includes people who inject drugs, as well as other people, including those who may be in correction facilities or those who interact with people who inject drugs and or sex partners and or people who have sex with men and people seeking evaluation for sexually transmitted disease. This is really important to note because I think there's a tendency for a lot of people to say expected adults of a certain age got vaccinated under universal vaccination guidelines that have been in existence for quite some time. However, the research shows that especially people who inject drugs or people who are experiencing homelessness have long histories of experience with the judicial system, including juvenile detention. They have a lot of rates of high mobility and experience in the foster system, and they may have missed childhood vaccination. So it's not enough to assume that because someone is of a certain age that they, quote unquote, must have gotten vaccinated in the past. Next slide, please. So there are specific settings in which hepatitis B vaccination is recommended for all adults, and this includes facilities that are treating people for STDs, facilities that are providing HIV testing and treatment, facilities providing treatment for drug use and prevention services, healthcare settings which are targeting services to injection drug users, and that includes syringe services programs, correctional facilities, as well as settings that are targeting MSM, hemodialysis facilities, and programs for end-stage renal diseases. And then last, there's sort of all types of institutional settings, so that might include locked mental health facilities, as well as any kind of correctional institution. Next slide, please. And we know this is an important issue because the research shows that we keep missing opportunities for adult vaccination of hepatitis B. So a 2002 study looked at all people with new hepatitis B infections and saw that 37% had reported getting treated for an STD. Almost 30% had reported prior incarceration. And then 56% had at least one of these issues. And so this is just an example of all the times that we could be vaccinating people, but we're not. Next. There are, however, some indicators that we know do help people complete the complete series for vaccination. And that includes when people who inject drugs are engaged with some kind of social services or have an outreach navigator or an outreach worker or case manager that they're working with. Interestingly, people with a longer injecting career, people who have been injecting drugs longer, are more likely to complete their vaccination series. So providers might think that they are less likely to, but I think these people may be more engaged with some of those pieces that we see are important for vaccination completion. People of a history of testing for HIV and hepatitis C vaccine do better at completing their series. People who use syringe services programs. And it's controversial, but if you can give financial incentives to complete this vaccination series, we know that that's really, really helpful. Next slide, please. But regardless of whether or not if somebody actually completes their series, it's really important to initiate vaccine at earliest contact. A hepatitis B vaccine administered intramuscularly produces an antibody response in approximately 30 to 55% of healthy adults under 40 after the first dose. After the second dose, it's 75%, and more than 90% have a protective antibody response after the third dose. So this suggests that even one dose is better than none, and that concerns about series completion is actually not a reason to not initiate the first dose. Next slide. That said, the WHO guidelines do suggest using an accelerated schedule to improve series completion for people who inject drugs. And so that means we give doses at day 0, 7, and then again at 4 weeks. And it's important to note that there is a booster shot recommended at 12 months. Next slide. So overall, I'm sorry, that was a really brief review, but we know that hepatitis B, acute cases of hepatitis B are increasing. We're seeing it in a population similar to that that's affecting who is getting hepatitis C, and that's people of younger age who are mostly white. That despite being a highly mobile, hard to reach population that may be reluctant to access care, people who inject drugs can successfully complete a 3-dose series for hepatitis B. Following the models such as Florida, it's important to consider targeted outreach campaigns, use vaccine registries, use mobile units, do what you can to help people complete their series, get the word out that this is important. And then use this framework to engage people who inject drugs and all sorts of other healthcare initiatives. And then last slide. That was really quick, but thank you for this opportunity to participate. And I'm going to turn this over to our state partners who can share their experiences trying to address these issues on the ground. Thanks.
Hi, everyone. My name is Jeff Caulfield, and I'm an epidemiologist and viral hepatitis prevention coordinator for the state of Maine. And I'm going to talk about hepatitis B in Maine today. Next slide, please. As you can see from the line graph, in 2015, the state of Maine saw a very steep increase in acute hepatitis B that continues to this day, 729% increase. This year, for 2016, Maine is the has the 9th highest rate of acute hepatitis B in the U.S. The year before, in 2015, we were 5th highest in the nation. And as you can see, with our rate continuing to increase, we didn't drop to 9th because of an improving situation. It's just that several other states are now experiencing the same thing that we are. Next slide, please. The 2017 acute hepatitis B risk factors, as you can see, for both hepatitis B and hepatitis C, injection drug use far exceeds the other risk factors. Maine has both a hepatitis B and hepatitis C problem going on right now and has been for the past couple of years. Both of these are linked to the opioid crisis. And as you can see, the third most common factor is incarceration. This is also a very high risk factor for us here. It overshadows the baby boomers, which are the traditional group that we usually see. Here in Maine, we're trying to address B and C at the same time and not to silo them, but it's quite difficult. Hepatitis C is usually getting more attention and testing, especially with the new treatment that is out now. Next slide, please. You can see from the demographics slide here, the demographics mirrors the demographics of the state of Maine. Maine is a very white state. And it's an older state. I think we're have the second oldest population in the nation. And so this really reflects who it is that's getting acute hepatitis B in our state. Next slide, please. The states with the highest rates of acute hepatitis B in Maine, as you can see the darker color there on the map, this is an area, part of which is called Down East. It's very rural. The two counties, Hancock and Washington County, are some of the most rural areas in the state. Penobscot County is where the city of Bangor is, and Bangor has had a really bad opiate problem for the past couple of years. So this is where the majority of our cases are coming from. We also have some other hotspots in the further southwestern part of the state as well. Next slide, please. Chronic hepatitis B rates, we've also seen an increase of this 71% in chronic B. Next slide, please. But the risk factors are quite different. Different groups of folks, new arrivals and baby boomers lead the risk factors for this. People who are foreign-born are overrepresented in chronic hepatitis B in our state. Next slide, please. For chronic hepatitis B, the demographics are quite different than what the general population is, as you can see from the pie charts here, even though the age is pretty close. Next slide, please. And a comparison between what the chronic rate is here for hepatitis B and what Maine information from the census is, you can see that African Americans and Asian Pacific Islanders are very overrepresented here for chronic hepatitis B. Next slide, please. And also where their distribution is as well, folks with chronic hepatitis B, we see more in the 3 counties that you see. Penobscot County was high for acute, is also high for chronic. But the 2 counties down in the southwestern part of the state, Cumberland and Androscoggin County, that's where the majority of our new arrivals usually get settled. And that's the population that we're seeing this from. Next slide, please. So prevention projects that we're working on now. So we're trying to target the 2 highest burden areas, Penobscot County and Cumberland County. And we're targeting facilities that work with the highest risk individuals of FQHCs and incarceration facilities. Next slide, please. So one of the things that we're doing is we're starting up a program where we provide provider education. This was based on a survey that was done at some of our FQHCs of barriers that providers said they had in speaking to their patients. So we're targeting those FQHCs to try to get them to increase testing, vaccinate, and linkage to care. The educational sessions include myself and 2 other of my coworkers from our HIV care division. And the things that we're helping the providers to do, as I mentioned, were things that they mentioned were barriers to them, like speaking to patients about their risk behaviors and just gaining more cultural competency. Next slide, please. We're also doing, we've been doing now for a few months, a hepatitis B vaccination outreach project. So we see a lot of patients that are hepatitis C positive, but have no vaccination for hepatitis B. And within a year, we get the labs on those patients and see that they are now infected with hepatitis B. And it's really a lost opportunity that we wanted to address. So what we do is through our database, we identify new hepatitis C patients that are not vaccinated and who are susceptible. And we have our field epidemiologists reach out to the patient's providers to recommend vaccinations. And we send the providers information and we send the patients information. And in our we had a 3-month pilot program of this, and we saw a 64% increase in the number of cases that received at least 1 Hep B vaccination after 3 calls to the provider. And we took this from a pilot program to, we're now doing it statewide. Next slide, please. Also, we're starting up a program where we're going into incarceration facilities, both in Penobscot County and in Cumberland County. And in those 2 high burden areas, we're going to be doing point of care testing in these facilities and then linkage to care upon the people's release. We're also doing an educational program for them, for the people who are incarcerated, and it's a train-the-trainer model. And so I go into the incarceration facilities and the reentry facilities, and the educational presentation I put on is really just Hepatitis 101, and also helps give them information about healthcare needs upon their reentry into the community. Next slide, please. I wanted to point out that the success of these programs and how we've been able to move ahead so well with them is because I have very enthusiastic, engaged partners in both of these counties. Another partnership that didn't work out was I had a large pharmaceutical company offer to fund our partner projects. which was very, generous of them and very generous funding that they wanted to give. However, all of my partners so far have declined to accept that. I'm part of Maine is part of the 1702 supplemental funding and the 1702 grant, and the supplemental funding that came out recently was a game changer for us. There was a lot of this stuff that I just mentioned that we would have been unable to do. Nearly all of it we would have been unable to do if we didn't have funding to help out our partners. Next slide, please. And that's it. Thank you for the opportunity to present information from Maine, and I'll pass it on to the next state.
Hello, everyone. Thank you for joining us today. My name is Katie Pack. I'm the Hepatitis B epidemiologist with the West Virginia Bureau for Public Health, Division of Infectious Disease Epidemiology. Today, I'll be talking about West Virginia's reportable disease law, surveillance and case investigation, the disease burden of hepatitis B, as well as the challenges to surveillance and the successes we've had thus far. Next slide. So according to West Virginia's Legislative Code 64 CSR-7, all healthcare providers, hospitals, and labs are reported or necessary to report hepatitis B results to local health departments within 24 hours of receipt. Next slide. Once these labs have been reported to the local health departments, they begin case investigation. They conduct patient interviews, they provide education on transmission, and perform contact tracing and partner notification. Upon completion of the investigation, the local health department submits the case to their regional EPI. They then review the case and send it through the electronic disease surveillance system, West Virginia EDS, to the state hepatitis B EPI for final review before it's then reported to the CDC via the Nationally Notifiable Disease Surveillance System. Next slide. For many years, West Virginia has had the highest incidence of acute hepatitis B infections in the country and the second highest incidence of hepatitis C. Over the last 3 years, we have made significant changes to hepatitis B and C surveillance for improved disease detection. For instance, the management of hepatitis B has been transferred to the Division of Infectious Disease Epidemiology. We've also implemented the West Virginia Electronic Disease Surveillance System, West Virginia EDS, and we've started receiving electronic lab reports from hospitals and labs across the state. This shift to electronic lab reporting has made the number of lab reports that we've received increase by about 60%. And it continues to increase as we've onboarded more facilities. In 2016, the hepatitis B and C surveillance evaluation reported more than 146,000 hepatitis lab results were received, and these were all managed by 2 full-time and 1 half-time part-time staff members in our division. Next slide. As you may know, West Virginia is a largely rural state, with more than 44% of the population living in rural areas. According to the U.S. Census Bureau, it's estimated that the population at 1,844,000 is nearly 18% of those people living under the poverty level. The population is predominantly white, non-Hispanic, and people between the ages of 18 to 64 account for about 60% of our population. The graph on the left here presents the distribution of acute hepatitis B cases by age and gender, with males and females between the ages of 30 and 49 accounting for about 62% of the cases. Next slide. This is a county-level map with the rates of acute hepatitis B per 100,000 population represented. As you can see, many of the southern counties have higher rates of infection. The coal industry in West Virginia is concentrated in the southern part of the state, and as that industry weakened over the past several decades, we've seen an increase in unemployment and subsequently an increase in the prescription and non-prescription opioid abuse. And this has led to our increased number of hepatitis B and C infections. Next slide. So this is a graph of the perinatal hepatitis B infection among infants and pregnant mothers from 2012 to 2017. We've seen an increase in the number of hepatitis B surface antigen positive women over the last several years. In the last 6 years, we've followed over 150 hepatitis B positive moms with only 5 infants diagnosed with perinatal hepatitis B infection that we've been reported. This emphasizes the importance of screening pregnant women for hepatitis B and ensuring that all birthing facilities have the necessary interventions ready for infants at birth. We are excited because we recently filled a position for a perinatal hepatitis B prevention program coordinator, and that's going to be moving forward very soon, and we're very excited about that. Next slide. This is a graph of the percentage of self-reported risk factors among hepatitis B acute cases, keeping in mind that each patient may report multiple risk factors. We found that drug use, both intravenous and non-intravenous or street drugs, were the most commonly reported risk factors and were reported by more than 1/3 of all cases. Next slide. So West Virginia's drug overdose death rate is more than twice that of the United States. We have the highest age-adjusted mortality rate in the nation, and that's the 3rd higher than the next highest state, which is Kentucky. Next slide. This map indicates the counties where opioid overdose deaths are the highest in the state. So as you can see, except for Berkeley County in the eastern panhandle, the cluster of deaths is mostly concentrated in the southwest part of the state. The West Virginia drug overdose deaths historical overview from 2001 to 2015 reviewed the use of opiates and polypharmacy in the state and concluded that the drug overdose mortality rate was more than double that of the U.S. Furthermore, from 2015 to 2016, our overdose mortality rate increased by about 25% to 52 overdose deaths per 100,000 population, the highest in the country. Next slide. So we do have a lot of partners that we work with fairly regularly. Let's see, we have 6 regional epidemiologists across the state. They are housed at the local health departments, and they assist their counties with their regional case investigations. They provide guidance to local health departments, and they review cases before they're sent on to the state health department. We have 49 local health departments in West Virginia. They perform the bulk of the disease investigations, communicating directly with patients, providing prevention and transmission education, as well as contact tracing and vaccine or post-exposure prophylaxis when necessary. The Division of Immunization Specialists provide hepatitis B vaccine to eligible children. They've conducted a CDC-funded adult Hep B vaccination project from 2012 to 2014, and they monitor infants born to infected mothers to ensure they receive all appropriate vaccinations to prevent hepatitis B via the Perinatal Hepatitis B Prevention Program. We also work with the Health Statistics Center. They provide information regarding hepatitis B surveillance on children born to positive mothers, and that data comes from birth certificates. And finally, the Division of STDs, HIV, and Hepatitis. They assist us with prevention efforts through the work of their disease intervention specialists. These DIS are assigned investigations and perform extensive record searches. They do home visits and make every attempt to track down these difficult to reach patients that we see with hepatitis. Next slide. So we do have lots of challenges, but also some successes to report as far as surveillance for hepatitis is concerned. For the challenges, many of the reports we have to review have no pregnancy information on female patients, and this is sometimes preventing us from following through with following the pregnancy and ensuring that the appropriate intervention is ready at the time of delivery. We have an extremely high volume of lab reports to review. In 2016, we opened over 900 cases of hepatitis B, both acute and chronic. And we know that most of the people who are infected with hepatitis B are asymptomatic. So unless they are being tested due to risk factors or other medical conditions, we aren't catching them all. And it is estimated that the amount of actual hepatitis B cases is 6.5 times the amount that are reported. Some of the cases that we investigate are considered lost to follow-up. This can be due in part to the highly mobile nature of some of the population at risk. Sometimes we get old, invalid, or no reported contact information. And in some cases, they have moved out of our jurisdiction, so it's difficult to follow up with them. The regional jail system in West Virginia does not automatically test inmates upon arrival. The inmate must request testing, show signs of or symptoms of hepatitis, or be a contact of a known case for testing to be provided. We do have some successes to report, which we're happy to do so. We do review every lab report we receive, both physical copies and electronically reported copies. The cases are opened at the state level. Investigation takes place by the local health departments and is reviewed by the regional epidemiologist before heading on to the state. So these investigations go through many levels of review prior to being reported to the CDC. We have onboarded many hospitals and laboratories for electronic lab reporting and plan to continue this process with more facilities. Our website provides lots of really good tools and resources for local health partners, health providers, and the public, including vaccine information, training tools, investigation guidance, and surveillance reports. We currently have received 2 CDC grants related to hepatitis, one for surveillance and the other for prevention. West Virginia is one of only several states that does not grant religious or personal belief exemptions for school immunization, so we have a really great vaccination rate. West Virginia does have a statewide registry for vaccinations. This allows us to update shot records for children, adolescents, and adults, and it helps prevent unnecessary immunizations as well as revaccinations. And we are, like I said earlier, very excited to have our perinatal hepatitis B prevention program coordinator on board. So thank you for your all's time and interest today. I'll be available later if you have any questions. Thank you.
Okay, great, thank you. My name is Carolyn Wester. I'm the medical director for HIV, STD, and viral hepatitis at the Tennessee Department of Health, and I appreciate the opportunity to present on behalf of my colleagues at the Tennessee Department of Health. So over the next 10 minutes or so, I'll provide a brief overview of epidemiology of acute Hep B in Tennessee, as well as overview of our vaccine funding, and highlight some of our current and proposed Hep B vaccination pilot programs to expand vaccination among at-risk adults. So on the slide that you're currently seeing, while Hep B will be the main focus of my presentation, I'd definitely be amiss without at least acknowledging the root of the infectious consequences that we're discussing today, or one of the roots, and that is obviously the opioid epidemic, and specifically the high opioid prescribing rates that so frequently catalyze the cascade of use and misuse that too often leads to injection drug use. This slide illustrates U.S. opioid prescribing rates per 100 U.S. residents by state, and while rates in Tennessee have fallen 15% since 2012, you can see that the prescribing rates remain high, even as high as in 2016. Unfortunately, it's no surprise that Tennessee and its central Appalachian neighbors are home to some of the highest rates of the downstream infectious consequences of the opioid epidemic, including hepatitis B. Next. Despite being vaccine preventable, cases of acute Hep B are high in Tennessee and have been on the rise. In this 2016 MMWR publication, which you saw Alice present, you can see in the top left figure that while rates of acute Hep B remained relatively stable in the U.S., represented by the dashed line, from 2006 to 2013, rates in Tennessee and 2 neighboring states, represented by the solid line, increased by 114% over the same period of time. In the figure on the right, we see that similar to what we've seen for acute Hep C, that over this same period of time, rates of acute Hep B have increased in both urban, represented by the light blue bars, and non-urban, dark blue bar settings, and that case rates are highest in the non-urban areas. And not shown here, but drawn from the same data, we see that in these 3 Appalachian states, the rates of acute Hep B were also highest among individuals who were non-Hispanic whites, male, and aged 30 to 39 years of age, and reporting a history of injection drug use. Next slide. This slide focuses on the cases and rates of reported confirmed acute Hep B in Tennessee. And it's important to remember that reported confirmed cases are estimated to represent only about 15% of the true number of acute cases in a jurisdiction. The table at the top illustrates Tennessee's cases and rates as compared to the U.S. number. Tennessee consistently ranks among states with the highest reported case rates. The map at the bottom illustrates acute Hep B case rates in Tennessee by county, and you can see that some of the highest case rates are located in the northeastern corridor of the state, particularly along the Kentucky border. In fact, about 60% of the cases of acute Hep B reported each year in Tennessee reside in these northeastern public health regions. Next. Beyond geography, the characteristics of the nearly 1,200 confirmed acute Hep B cases reported during this 5-year period of time are as follows. The mean age, about 42 years, and of note, that's about a decade older than the mean age of our acute Hep C cases, indicating a vaccine effect. And there's a preponderance of acute Hep B cases among men, that's a moderate preponderance, and also among non-Hispanic whites. As for risk factors, nearly 80% of the individuals with reported acute Hep B in Tennessee reported at least one risk factor, which I'll break down in a subsequent slide. Next. Before we get to risk factors, in this slide, we break down the acute Hep B cases reported in Tennessee over the same 5-year period of time by age on the x-axis and gender by color, females in red and males in blue. Recognizing that Hep B has been an ACIP recommended childhood vaccine since '91, I placed a red arrow at the age at which children born in 1991 would have been in 2012, or age 21. And you can see that very few cases occur to the left of that red arrow. Additionally, it's important to note that while a substantial number of reproductive age women, represented by the red bars on the left half of the graph, continue to be acutely infected, which can potentially transmit into perinatal infection. Next slide. In this graph, we break down the specific risk factors reported by the individuals who reported at least one risk factor. And of note, the risk factors are not mutually exclusive. And I apologize that some of the wording may be difficult to read, but moving from left to right, 89% self-reported sexual contact, 34% reported non-injection drug use, 22% reported a history of incarceration, and 22% also reported a history of injection drug use. Some of the less frequently reported risk factors include transfusion, unsanitary tattooing and piercing, dental work or surgery, residence in long-term care facilities, hemodialysis, and occupational exposure. Next slide. Ideally, we'd like to provide Hep B vaccination broadly to at-risk populations, but the reality is that we have limited funding for Hep B vaccination to serve or underinsured at-risk adults. This slide illustrates the funding that we have to provide vaccinations for safety net populations. In terms of ongoing federal funding, we have the VFC program, which provides ACIP-recommended vaccinations free of charge to eligible under or uninsured children less than 19 years of age, and covers immunizations against 16 different diseases, including Hep B. The 317 funding provides a limited supply of vaccinations for priority populations listed on that slide. It's important to know that while it's permissible to use the 317 funding for all of these populations, because the funding is limited and the need is great, particularly in non-Medicaid expansion states like Tennessee, the reality is that these funds are pulled in a lot of different directions for a lot of different vaccine-preventable conditions. In Tennessee, 317 funding is used primarily for vaccine administration in health departments to under or uninsured adults for flu vaccine, which is the vast majority of the doses, as well as known exposures to a variety of vaccine-preventable conditions, one of which is Hep B. Additionally, given that some 317 funding also needs to be reserved for outbreak response, state immunization programs are understandably reluctant to commit too much of 317 funding for adult Hep B vaccination up front. So again, the reality is that 317 funding for Hep B vaccination, at least in Tennessee, is primarily used for known case contacts, highlighted in red on this slide. The limited focus due to the limited supply of the vaccine results in a lot of missed opportunities to prevent acute Hep B among other at-risk populations, which we've heard today, including incarcerated individuals, STD clients, and people using injection and non-injection drugs. In Tennessee, we were able to expand the Hep B vaccination services into one of these service areas through a relatively small PPHF grant, which was awarded in 2012 and ultimately continued with state funds. Next. The red circle on this map simply indicates the location of the public health regions where we operated our Hep B jail vaccination program, which was the program we operated with these funds. Next. The program, run by a 3-person team, 2 nurses and an administrative person, partner with local health department and county jail staff to provide routine opt-out Hep B vaccination among inmates. The goal of the program is simply to reduce rates of acute Hep B by providing vaccination to previously unvaccinated adults. Operationally, the program focuses on our incarcerated adults in jails in the public health regions with the highest case rates and provides viral hepatitis education and 3-dose Hep B vaccination in 27 jails in that area. Over the past 5 years of the program, over 24,000 doses of the 3-dose vaccination have been administered. About half were first doses, and about a quarter were second doses, and a little bit less were third doses. Most recipients were male and non-Hispanic white, representing the population in that area. And from 2012 to 2016, the rates of acute Hep B decreased by 21% in the 4 public health regions participating in this program, 8.1 down to 6.4 case rate, and decreased by 19% in all the other public health regions. While the percentages of decrease are similar, we're encouraged that the rates of Hep B in these public health regions are actually going down, especially since these are the regions that, unfortunately, at the same time have been experiencing increases in some of the other downstream consequences of the opioid epidemic, such as acute Hep C, fatal and non-fatal overdoses, and neonatal abstinence syndrome. Next, some of the lessons that we've learned programmatically is that the jail vaccine project is feasible, well accepted, can be operated by a modest budget that includes staffing and vaccinations, and provides a framework for very valuable partnerships, particularly in the context of providing Hep A vaccine, Hep C testing, and linkage to services upon release. Improvements were made along the way, including strategies to avoid giving booster or unnecessary doses, strategies also to increase completion rates, and we also noticed some missed opportunities, particularly as we're seeing an uptick across our state of Hep A and an outbreak in our one of our metropolitan areas, where if we had used the combined Hep A and Hep B vaccination from the start, we might be a little better off, although we recognize that would have doubled the cost of our vaccinations. Next slide. And to wrap up, some of our next steps in jails, we're utilizing the existing infrastructure now to deliver Hep A vaccination. We are transitioning from a 3 to a 2-dose Hep B vaccination protocol. And in health departments, we're also transitioning to the 2-dose vaccination, and we're ramping up to start an STD pilot for basically the individuals you can see on the slide. And last, obviously, we'd love to continue to explore strategies to expand the utilization of our 317 supply for at-risk adults. So thank you very much. And on the very last slide, I just want to recognize some of my colleagues who have contributed to the work in this presentation. Thank you.
Great. Thank you so much to all of our speakers today for those incredible presentations. I feel like in a very short period of time, we covered a lot of great information and really innovative and important strategies for responding to the rises in acute HBV that we're seeing. And we only have a few minutes for questions. So if you want to ask anything before we wrap up, please feel free to include that in the chat box. I did want to just take the facilitator's prerogative and ask the first question. I know Maine and Tennessee, you mentioned some education and vaccination efforts in jails and prisons, and I know that that's a really important setting for both vaccination, education, and testing for B and C. And I was wondering if you have any advice or recommendations for getting in the door and building those relationships, because I know a lot of health departments struggle with getting into those settings, particularly if the jails are privately run or just, different challenges with building up partnerships. So if you have any quick lessons learned or recommendations for others who are looking to strengthen those partnerships.
This is Jeff from Maine, and I was fortunate enough that the FQHC that I'm working at, both FQHCs that I'm working with, already had pre-existing relationships with a number of incarceration facilities.
And this is Carolyn from Tennessee. Our team started from the ground up, and we, as you mentioned, were very enthusiastic about offering education, vaccination, and also testing. But I think giving a menu of services and allowing the jails to pick what they would like, most were not interested in testing. However, they were very happy to receive the education and the vaccinations for their inmates. And I think the other thing is the team just needs to be super flexible, because, this is a wonderful add-on service. It's a public health priority, but it's not necessarily a priority within the correctional system. So I applaud our jail vaccine team, because they've really worked with them over and over again to schedule and reschedule clinics, and often wait long hours while lockdowns were completed and things like that.
Perfect, thank you. So I don't see any other questions, so I'm going to turn it back over to Kate to wrap us up.
Thanks, Alyssa. Well, I think there are a few questions that we could fit in from those that are coming in online. And I'm going to read one or two of them out in the couple of minutes that we have left. I think they're just coming in. One is...
thanks. I didn't see those.
Yeah, no worries. So I think I'm going to direct this to Carol first, Carolyn, since you had mentioned the 317 program. And the question is, has anyone had success expanding the 317 vaccines to hepatitis B? And I think the 317 program does cover hepatitis B vaccine, but I think the question is related to getting additional funding for Hep B specific vaccine supply.
So this is Carolyn. We work very closely with our immunizations program. They run a sensational show, and we've learned a lot about VFC and 317 through them. We have not been able to obtain additional funding. I know they've gotten additional funding in outbreak scenarios, but not necessarily for just routine expansion among at-risk adults for Hep B.
All right, Katie or Jeff, would you like to chime in on
that? This is Jeff from Maine. I am not familiar with the 317 program, so unfortunately I don't think I can add much to that.
Yes. This is for Tennessee. I know Tennessee has a large private prison system. Are you getting equal participation from private prisons?
So we've been talking about county jails in our talk, but in terms of the Department of Correction, which is state-run and contracted out to a medical provider, they provide Hep B vaccination to at-risk adults, but it's not a routine intake immunization.
Thank you.
All right, and I know we're at the top of the hour, but we have so many great questions. I'm going to fit one more in. As we know, we've talked a lot about the importance of improving adult vaccine coverage, but I wanted to touch on testing for a minute. And one of the questions that came in, and please feel free to answer this in terms of different risk populations. But the question was directed originally at Carol. Do you test the inmates to ensure they are unvaccinated? If not, how do you identify the unvaccinated?
Okay, thank you. We do not do any kind of serologic testing in the jails. However, we have a statewide immunization registry, and I'm kind of glanced over that quickly, although the details are in the slides, so I apologize for that. But our team gets a roster of the jail the day before they go. They have their schedule 2 months ahead of time, and the day before they go into a jail, they get the roster. They match it against our statewide registry, and then when they go into the jail, most of that work's done, but the roster can change up at the last minute. So they also bring in tablets that are connected via Wi-Fi to the state immunization registry. So that's how they ensure that they're not providing unnecessary vaccine, and they're also making sure that people are receiving their vaccination on schedule.
Thank you. And then one more, just because I've received this question about 3 times now for Maine, for Jeff. Why did your partners decline funding from large pharmaceuticals?
Yeah, good question. One of the partners, their leadership said that they did not want to be involved. They didn't want to accept funding from a pharmaceutical company. The other one felt that they didn't have the capacity to accept that funding at this point, and that they would consider it down the road.
Thank you for addressing that. All right. Well, I know we are over time, so I'd like to go ahead and wrap up. We had a lot of questions came in, and I wanted to let members of the audience know that we've received them and we have recorded them in the system. So we will be following up with each of you directly and answering them and directing them to the presenters to answer them for you via email. And if there are any other follow-up questions that you have today for any of the presenters, please feel free to email them to us at connect@hepbunited.org. And also, we will be sharing a few of the presentations that we have permission to do so after the webinar, as well as recordings. You should be able to have also email addresses for all of the presenters who have shared them at the end of their presentations. And finally, I just wanted to thank everyone and all of our speakers so much for sharing the rich data. It's been extremely insightful to see where we are seeing the acute HBV infections, and really grateful for your time and your expertise today. And thank you to everyone for joining us. Please, as you exit, if you would help us to share your feedback and fill out a brief survey as soon as you close out your window. Thanks again and have a great day.